Hi everyone, welcome to our module on critical care medicine. Before beginning with the video, I'd like to request all of you to subscribe and keep supporting. In this video, we are stepping into critical care medicine, which is where physiology becomes clinical. So everything we discuss here, whether it's lung failure or shock or acid-base imbalance, so all these things directly affect survival in the intensive care unit. So we will cover it under five major areas. The first thing is the acute respiratory system, mechanical ventilation, acid-base interpretation, shock, and toxicology. So if this lecture series is helping you, please do contribute with the link that is on the screen and that's also pinned in the description. You can contribute to us with any of these payment methods. So uh, we're going to focus on areas like acute respiratory distress syndrome, mechanical ventilation, acid-base disorders, shock, toxicology. So all these things are life-threatening conditions. So these are not just isolated topics, they are all interconnected, and questions in exams are usually built around real clinical scenarios and we need to solve them. Let's begin with the acute respiratory distress syndrome. So, this is a condition where the lungs become filled with fluid, but importantly, this is not because of heart failure, and this distinction that it's not because of heart failure is very crucial. The underlying problem is diffuse alveolar damage. So, these alveoli are the primary sites of gas exchange, and there occurs diffuse alveolar damage. And what happens in normal alveoli is that these are air filled and this allows the oxygen to pass into the blood, but in this condition they become filled with protein rich fluid. In ARDS they become filled with protein rich fluid. This severely impairs oxygen transfer and leads to profound hypoxia. The common triggers for this includes, the most common cause is sepsis, which is a widespread infection that triggers a massive inflammatory response. Other causes could include aspiration, where the gastric contents enter the lungs, and also trauma. So all these common triggers trigger inflammation, which is the key mechanism here. So the inflammation is the key mechanism, and this process begins when the inflammatory mediators or inflammatory cytokines are released. These attracts neutrophils into the lungs, and these neutrophils damage the capillary lining. So once this barrier is disrupted, the fluid leaks into the alveoli. So now you have the fluid where the air should actually be. There's fluid, and this fundamental problem here in this condition of ARDS is that this air is replaced with fluid. So as the disease progresses, the leaked fluid then combines with dead cells and proteins like fibrin, and this forms structures called as the hyaline membranes along the alveolar walls. So these membranes makes the diffusion barrier thicker. This makes the diffusion barrier thicker, and what eventually happens is that oxygen cannot easily pass into the blood, and diffusion impairment occurs. So for diagnosing this hyaline membrane disease, we use the Berlin's criteria, and the criteria consists of four different conditions. So the first thing is timing. The condition must occur within a week of a known insult. The second thing is imaging, and the imaging should show bilateral opacities, meaning that both the lungs are involved. Then there's fluid accumulation, and this fluid accumulation should not be because of heart failure. And finally, there must be impaired oxygenation where the PaO2 by FiO2 ratio is less than 300. So a lower ratio less than 300 indicates worsened oxygenation. So the management of this condition is mainly focused on two main goals. The first thing is that we have to treat the underlying cause, and the second thing is that we have to give supportive oxygenation. This is usually done using mechanical ventilation. So, but here's the case: it's like ventilation itself can damage the lungs if done incorrectly. So, we use something like a lung protective strategy where we use low tidal volumes of around 4 to 6 ml per kg, and uh, we to prevent the over distension of the alveoli, and we also use positive pressures at the end of expiration to keep the alveoli open. This prevents the repeated collapse, and reopening. So we call it the recruitment and de-recruitment injury. And because of this lung protective ventilation, this recruitment de-recruitment injury is minimized, and this leads to proper management of the condition. This prevents the repeated collapse and reopening, which would otherwise cause further lung injury. Now let's understand mechanical ventilation more systematically. So the goal is to maintain the oxygen levels. The second thing is that we need to remove the carbon dioxide, and thirdly, we need to avoid causing additional damage, additional lung injury. Uh, so in order to study about mechanical ventilation, we need to know about few volumes and few lung capacities, lung volumes and lung capacities. The first thing is the tidal volume, which refers to the amount of air that is delivered with each breath. So if this volume is too high, it overstretches the alveoli, it causes lung overdistension, and when this tidal volume is too low, uh, a low tidal volume of 4 to 6 ml per kg, prevents this recruitment de-recruitment injury, prevents overdistension, and so it's safer in acute respiratory distress syndrome. We always need to use low tidal volume of around 4 to 6 ml per kg. So this helps us prevent the volutrauma or barotrauma, what we call, to prevent the overdistension of the lungs, because the ventilation associated lung injury. So we'll also try to understand about the pressure that is applied at the end of expiration, which is also called as positive end expiratory pressure, or PEEP. So this pressure keeps the alveoli from collapsing, prevents the alveoli from collapsing. So what happens is that the collapsed alveoli cannot participate in gas exchange. So keeping them open helps us improve oxygenation, and it also helps in repeated opening or closing injury. So this low tidal volume and positive end expiratory pressure, maintaining a positive end expiratory pressure, so these two are vital conditions in order to prevent the recruitment de-recruitment injury in cases of acute respiratory distress syndrome. Now we'll also try to understand about oxygen concentration. So whenever we give high oxygen, so it's useful in short term, but prolonged exposure to very high oxygen levels can generate free radicals, and can damage the lung tissue because of the oxygen toxicity or free radical mediated lung injury. So we always aim to keep the lowest oxygen concentration that helps us achieving adequate oxygenation. Yeah. So FiO2 is the fraction of inspired oxygen. So it's nothing but the percentage of oxygen that is delivered to the at the diffusion membrane. So whenever there's high FiO2, this is a short-term benefit. When there's prolonged use to high concentrations of oxygen, this leads to free radical associated lung injury. So we need to avoid prolonged 100% oxygen. Now let's try to understand about how we control carbon dioxide and how we adjust ventilation according to the carbon dioxide requirements in our body. So carbon dioxide levels are determined by how much air is being moved inside and outside. So whenever this carbon dioxide is elevated, we increase the ventilation by either increasing the rate of respiration or either increasing the tidal volume or volume for each breath. So this is an important distinction where ventilation controls carbon dioxide, while oxygen or oxygen fraction or oxygenation is influenced by factors like alveolar recruitment and oxygen concentration in the inspired air. So now let's try to discuss and understand about acid-base interpretation and acid-base disorders. As we all know, this is one of the highest yield areas in any areas of medicine. So the key to understanding this acid-base disorders is that we need to follow a structured approach. First, we need to look at the pH to determine whether the blood is either acidic or basic. So whenever the pH is less than 7.35, so we can think that it's the patient is in acidosis. Whenever it's greater than 7.45, we can call it alkalosis. Next, we need to evaluate the carbon dioxide levels to see if there is any respiratory component. Then we need to look at the bicarbonate to assess the metabolic component. Now let's focus on let's try to focus on the metabolic acidosis. So So this metabolic acidosis is characterized by low pH and low bicarbonate. It occurs either because the acids accumulate or bicarbonate is lost. So to differentiate causes, we calculate something that's called as the anion gap. This helps us determine whether there are unmeasured acids present in the circulation. So whenever this gap is high, it means that acids are accumulating. So for example, in cases of diabetic ketoacidosis or lactic acidosis, this anion gap could be high, and this could indicate that acids are accumulating. So if this gap is normal, it means that bicarbonate is being lost. Such as in cases like diarrhea. We can remember the causes of high anion gap metabolic acidosis using a mnemonic that's called as MUD PINES. So M stands for methanol, U stands for uremia, D stands for diabetic ketoacidosis, P stands for propylene glycol, I stands for isoniazid and iron, L stands for lactic acidosis, E for ethylene glycol, and S for salicylates. Whereas with regards to causes of normal anion gap metabolic acidosis, anion gap is nothing but the difference between the sodium, the uh, so the sodium which is subtracted by the concentration of the negative ions. So the negative ions like chloride and bicarbonate. So sodium minus chloride minus bicarbonate gives us the anion gap. Whereas the causes of normal anion gap metabolic acidosis can be memorized using the mnemonic ARDS. So H stands for hyperalimentation, A stands for Edison's disease, R stands for renal tubular acidosis, D for diarrhea, A for acetazolamide, S for spironolactone, and the other S is for saline infusion. So we can also predict how much compensation needs to be given using a formula that's called as the Winter's formula. So whenever there's a case of metabolic acidosis, what we need to do, or what our body needs to do, is it tries to compensate with the respiratory system. So whenever there's metabolic acidosis, there's a compensatory respiratory alkalosis. So in order to, whenever this bicarbonate is lost, the carbon dioxide is actually lost too. So this is called as respiratory alkalosis. So the amount of carbon dioxide that's expected to be lost can be calculated using the formula 1.5 into bicarbonate plus 8 plus or minus 2, and this formula is called as the Winter's formula, and this PCO2 helps us determine the level of compensation. If the actual CO2 that's expelled is less than is not equal to the expected, so this could lead to a mixed disorder. Like it can be something like metabolic acidosis that's associated with respiratory acidosis, which is a abnormal finding, which is not a common condition. It's a mixed disorder. Now we'll try to understand about metabolic alkalosis, which occurs when the bicarbonate is elevated, and alkalosis is nothing but high pH of greater than 7.45, whereas metabolic alkalosis indicates that there's high bicarbonate in the blood circulation. The common causes of this condition includes vomiting, where there's loss of acid, loss of all the H plus, you call it, and the other common cause is diuretics, which leads to reduced excretion of bicarbonates. Uh, this metabolic alkalosis usually happens due to the loss of acids, such as prolonged vomiting or use of diuretics. And the key to solving these questions is that we need to think in a structured way. We need to identify the primary problem, then we need to calculate the gap, the anion gap if needed, and also we need to assess compensation using the Winter's formula, whether the required compensation is happening or not. So that's a key thing that we need to remember. Now let's move to shock. So shock is nothing but a condition where the tissues do not receive adequate blood flow, and this inadequate tissue perfusion could lead to reduced oxygen delivery, and eventually this could lead to cellular dysfunction. The core problem in shock is that there's failure of circulation, and there are four main types of shock. So one of those is hypovolemic shock, which occurs due to fluid loss, such as in cases of bleeding or dehydration, whereas cardiogenic shock occurs when the heart cannot pump effectively, and obstructive shock occurs when there is a blockage in the circulation, such as in cases of pulmonary embolism. And distributive shock finally occurs when blood vessels are actually dilated excessively, as seen in cases of sepsis. So this distributive shock is also associated with disseminated intravascular coagulation, or DIC. So each type has a distinctive pattern of pressures, cardiac output, and vascular resistance, which we're going to study in the next slide. So in this slide, we're going to study about how the pulmonary capillary wedge pressure, how the cardiac output, and how the systemic vascular resistance varies in these four types of shock. In hypovolemic shock, what actually happens is that there's reduced pulmonary capillary wedge pressure, and also there is reduced cardiac output because of reduced circulating blood volume, and also there's increased systemic vascular resistance in cases of hypovolemic shock. Whereas cardiogenic shock is associated with increased pulmonary capillary wedge pressure, reduced cardiac output, and increased systemic vascular resistance. And obstructive shock might be associated with a reduced or increased pulmonary capillary wedge pressure, but it is characterized by an increased systemic vascular resistance along with a decreased cardiac output. And finally, distributive shock is associated with reduced pulmonary capillary wedge pressure. There is increased cardiac output in early stages of distributive shock, and also there is reduced systemic vascular resistance. So the type of shock in which pulmonary capillary wedge pressure is elevated for sure is the cardiogenic shock, whereas cardiac output is increased in early distributed shock. In all other conditions of shock, the cardiac output usually decreases, whereas systemic vascular resistance is decreased in cases of distributive shock, whereas in all other types of shock, the systemic vascular resistance generally tends to increase or be on the upper end. So sepsis is a particularly important cause of shock, and we need to really discuss about it. So in early stages, what happens is that the blood vessels dilate, and this could lead to warm skin, this could lead to vasodilation, and also increased cardiac output. Whereas in late stages, blood pressure drops, there occurs hypotension, and eventually this leads to organ failure. We can divide this distributive shock associated with sepsis into warm shock and cold shock. And treatment depends on the type. So treatment of shock depends on the type of shock. Hypovolemic shock is usually managed with IV fluids and blood transfusion, whereas cardiogenic shock is managed with ionodrops. Obstructive shock helps us relieve the obstruction in cases of, like example, whenever there's a case of pulmonary embolism, we try to manage that pulmonary embolism, and this helps us relieve the obstruction, and this leads to management of the obstructive shock. Whereas in cases of distributive shock, we manage with medications that constrict the blood vessels, and also give fluids along with vasopressors. Finally, let's try to look at the two important toxicological conditions. So carbon monoxide poisoning occurs when carbon monoxide binds to hemoglobin with very high affinity and forms carboxyhemoglobin. This prevents the oxygen from binding, and also prevents the oxygen from being released into the tissues. So even if oxygen is present in the blood, it cannot be delivered effectively. So cyanide, so this is how this carbon monoxide poisoning occurs. So this causes the left shift of the oxygen dissociation curve. This leads to increased oxygen affinity and reduced unloading at the tissues. This is characterized by findings like headache, dizziness, confusion, and cherry red skin. The important point in carbon monoxide poisoning is that PaO2 may be normal, but the oxygen content is low. Whereas in cases of cyanide poisoning, the cyanide poisoning works differently. It blocks the electron transport chain. It inhibits the cytochrome C oxidase of complex 4 of the electron transport chain, and this leads to poisoning at the cellular level, where the cells cannot use oxygen, and this is also called as histotoxic hypoxia. So this is managed with drugs like hydroxycobalamin and nitrates, where hydroxycobalamin binds to cyanide to form a more potent cobalamin, which is excreted by the kidneys. So the key difference between carbon monoxide poisoning and cyanide poisoning is that in carbon monoxide poisoning, the oxygen cannot be delivered, whereas in cyanide poisoning, the oxygen cannot be utilized. So this distinction between carbon monoxide poisoning and cyanide poisoning is very much tested on all the kinds of exams. So in this video, we cover the critical care concepts by trying to connect physiology with clinical applications. So if you try to understand these mechanisms, not just like the definitions, you'll be able to solve even complex questions very easily. So in the next video, we'll continue building on this foundation. Till then, I'd like to request all of you to subscribe and keep supporting. I'll be right back with another video. Thank you so much. Bye.